Hafa and welcome to another episode of My Story. I'm your host, Janella Carrera. In this episode, we're going to be talking more about cancer research within the region. We have joining us all the way from Hawaii via Skype, Dr. Lee Buenconsejo Lum, sorry about that. She's the principal investigator of the Pacific Regional Central Cancer Registry. Dr. Lum, thank you for joining us on this show. I hope everything's well with you there in Hawaii right now.
Absolutely. Hafa Adai and happy holidays to everyone. Thank you so much for the opportunity.
All right, thank you so much. Well, let's begin. I know that you, with your work, there's a lot of data gathering about cancer and cancer research within the CNMI and Guam and you know, the general Pacific region. But could you talk a little bit more about what you do, what you do specifically, and then of course what the registry does as well?
Okay, sure. Thank you. So I am a family physician by training. So I'm an MD, medical doctor in family medicine. And I started working in the Pacific along with Dr. Neil Palafox in 2002. Dr. Palafox, many folks in Guam and CNMI are familiar with him and his work. He's been working with the U.S. Pacific through the Marshall Islands and with the other jurisdictions since the late 90s. Mm-hmm. But my work started with him, and we started working with many of our colleagues and the hospital and public health sectors in the 6 U.S. affiliated jurisdictions. We started that in 2002, mm-hmm. And really it was a call from the physicians who are noticing that cancer was being diagnosed at very late stages, very advanced stages. Mm-hmm. And Dr. Palafox had already by that time been an advocate for cancer in the Marshallese population because of the Pacific Nuclear Weapons Testing Program. And so he had the opportunity to speak at several national venues, and the National Cancer Institute was basically intrigued and said, you know, if we could get you some additional funds, could you help us better understand this? But to do this, that means there has to be a kind of a systematic way to characterize and identify how much cancer is actually present in these jurisdictions, and also what the capacity is. So what's the health system capacity to diagnose cancer and treat it, but also what is the public's capacity and understanding. So that's really been what our work has been focused on primarily since 2002, 2003, is really to help build that capacity. And so as part of that, each jurisdiction has their own comprehensive cancer control program, or CCC or Comp Cancer, mm-hmm. And also each jurisdiction has their own cancer registry. So here at the University of Hawaii, we help to coordinate those regional efforts. And so for me personally, I am the principal investigator of the registry, which means that I oversee all of the registry operations in each of the 6 U.S. jurisdictions. We do standardized training and measurements and evaluations and other kinds of things, and help to generate reports that then the cancer programs and public health and the hospitals can use to better first understand how much cancer burden there is, but then also to design effective public health programs, and then ultimately to look at research. So that's kind of in a nutshell what all of us have been doing there since 2003.
Okay, and you said 6 jurisdictions, right?
Yes.
Could you name those 6 jurisdictions?
Sure. So these are the 6 U.S. affiliated Pacific Island jurisdictions, or US API. And so the 3 flag territories are Guam, CNMI, and American Samoa. And then the 3 freely associated states include the Republic of Palau, the Republic of the Marshall Islands, and the Federated States of Micronesia.
Ah, I see. Okay, I see. You mentioned that you were working with another physician early in like 97.
Mm-hmm.
And
Dr. Neil Palafox.
Yes, Dr. Palafox. And at the time that you were noticing these late stages of cancer diagnoses, did you have an idea of what may have been causing it at the time? Why it's late diagnoses as opposed to an earlier diagnosis?
Sure, yes. One of the first things that we as a regional group did was to actually do a study to look at and exactly to try to answer those questions. So the conclusions of that, and these are the 2002 Pacific Cancer Assessments. There's a whole bunch of a series published on that. And so it was really multifactorial. The first is that there actually wasn't a lot of community awareness of risk factors for cancer and or what cancer was. In some places, there wasn't even really a word for cancer in their native language. And or there was, but it was so taboo or shameful to speak of it. And there was so much fear that they didn't want to go and seek treatment. And in Guam and CNMI, that latter part, that fear and the shame of having something wrong with you, that actually emerged as a big factor. So that's one thing, is kind of on the public or the patient awareness side and willing, and kind of just that understanding of, hey, something's wrong, maybe I should see a doctor.
And removing that stigma behind it.
Right. So that's definitely one, huge component that a lot of folks in each jurisdiction has worked really hard to try to overcome. But then there were some challenges on the health system side, and there still remain some challenges. So some cancers just are very difficult to diagnose anyway. They many cancers just arise sporadically, meaning they're not genetic, they're not passed down, and they develop in some people who have a lot of risk factors, i.e. a lot of tobacco use. But sometimes cancers appear in people that don't seem to have any risk factors, right? So those cancers are always the ones that are harder. You can't do too much about that except to be aware that, hey, if I don't feel right, I need to see my doctor. But many of the cancers, especially the ones that we see, are, you could do something about it. Like you could help to prevent or lower your risk of cancer if you stop smoking, ate a healthy diet, lost weight, didn't drink as much alcohol, got some immunization. So you have kind of the preventable, cancers that have some preventive means. And then you have cancers that can be screened for and caught early. And so those primarily are breast cancer, cervical cancer, so this is the female cervix, and colon cancer, colorectal cancer, and lung cancer in certain high-risk individuals. Now there are screening tests for that, and prostate. So those are considered the screenable cancers. And what we found in 2002 was that there wasn't really well coordinated or really, even sometimes really available screening programs and sometimes the screening tests. And it's because some of the tests, say for example, colorectal cancer, which is now a very big emphasis currently on Guam. The Guam Cancer Program is very active, as is the one in CNMI, but for this next 5 years, they're really focusing on colon cancer. But the screening tests, there's 3 screening tests that are acceptable for colon cancer, but they range in price, from about $3 a test all the way to several $1,000s with a colonoscopy. And depending on insurance and also patient preference and where the patient is able to seek health care, right? There's a lot of factors that may be barriers to receiving those screening tests. So that was a problem. And then in some jurisdictions, not quite as much in Guam, but in Saipan to some degree, there was a little bit of a challenge in getting cancers diagnosed. And in part because at the time, this is back in 2002, there wasn't like on Saipan. So of course, Tinina and Rota have health centers, but they don't always have regular physicians there, right? So folks either come to main Saipan Island, or where depending which island they'd come to Guam because Guam may be closer. But anyway, they'd have to fly off island for care, right? And for diagnosis. And so if you don't have the biopsy capability, meaning the ability to use an ultrasound or kind of stick a needle and get some tissue, or if you don't have a pathologist on island, or maybe you do, but those specialized testings aren't done on island, then they have to be sent off to, say, Honolulu or Los Angeles, right? Or you don't have a CAT scanner. All of those things are barriers to diagnosis. And then on the treatment side, Guam certainly now especially has full service full service capability. They can diagnose, they can screen, they can treat with surgery, with chemotherapy and radiation therapy. In CNMI, it's still primarily limited to surgery and some chemotherapy. But many patients will still go off island, meaning off of Saipan, to get that initial part of chemotherapy, and then maybe they'll be able to do the rest of their chemotherapy at home in Saipan. But that's not the case in the other of the four, jurisdictions.
I see. All right. Well, we're going to throw to break real quick, and when we come back, we'll continue more this discussion on cancer within the region, and maybe going forward, if any benefits have been felt or seen since the research began. We'll be right back. Stay right there. Hafidin, welcome back to My Story. I'm your host, Janella Carrera, and before we went to break, we had Dr. Lee Buenconsejo Lum talking about the research that they began over a decade ago regarding cancer here in the region within Guam, CNMI, and the Federated States of Micronesia, Marshall Islands, American Samoa, and did I miss another one? Palau.
Yeah.
Yes. So Dr. Lum, you were talking a little bit about the challenges earlier, that these jurisdictions face when it comes to diagnosing cancer and treatment and prevention and all of that. Since your research began, or since you and Dr. Colfax.
Halifax, actually, Halifax, yeah.
Since you began your research, have you noticed any changes or any benefits that perhaps the agencies, whether nonprofit or government, that you've partnered with were able to use and apply to the island so that diagnoses happens at an earlier stage rather than a later stage?
Sure. Yes, there's been tremendous progress, actually, in all of the jurisdictions, but especially in Guam and CNMI since we started. Just to give you some kind of quick number and context, for CNMI, about 63% of their cancers are related to tobacco, and about a third of cancers are related to obesity. And in Guam, there's about 60% of their these are adult cancers that are related to tobacco, and about 30% related to obesity. So and the reason that I share those numbers is that conveying the numbers in that way tends to help send a public health message, which is really where a lot of the improvements have been. So certainly in both places, on the policy side, they've made tremendous strides in terms of tobacco prevention and control and legislation, and trying to get the restaurants and hotels and other places to be smoke-free, so that the general population is not as much exposed to tobacco, since basically 60% of cancer is related to tobacco in both of these jurisdictions. So the other policy related pieces is there's been some movement to help with healthier nutrition in terms of salt reduction or less sugar sweets in beverages, and all of those things we can help to combat all of chronic disease. So this is diabetes, obesity, but they're also major risk factors for cancer. So a lot of policy work. In terms of other things in Guam and CNMI also, there's been a lot of work done with betel nut. And first to just try to understand, so it's well known that betel nut by itself is a cancer cause. It causes cancer in and certainly in the way that many of the Northern Pacific Islanders utilize it, it's mixed with tobacco and sometimes other substances. And so the combination of tobacco and alcohol is both cause cancer by themselves, and then they're introduced at young ages. And so there's been a lot of work around actually learning more about what makes the betel nut so addictive, and that is in part because they're now, this is with Dr. Yvette Polino and others at the University of Guam, are working on a cessation program. So similar to how we have very structured programs to help people quit smoking and quit tobacco use. Dr. Polino and others are working to try to help betel nut chewers quit betel nut, which is really important. It's going to help a lot reducing the oral cancer, the cancer of the mouth and the throat. Other things that have been done is a lot of work has been done on immunizing against the virus that causes cervical cancer, and this is the human papilloma virus, or HPV.
Right.
And so both jurisdictions have done a really great job. CNMI really a leader in terms of getting a lot of their 12, 13, 14-year-old girls.
Oh, okay, that's wonderful.
Yeah. So that's that. We won't see the impact on cancer yet because it takes generally about 20 or so years. But what we do anticipate is within the next few years, we actually anticipate being able to see a little bit less abnormal pap smears. And then hopefully within the next 15 years, being able to see less cervical cancer.
I see.
And that's really kind of what we're hoping for with the HPV vaccination campaign.
There's actually two people that I've interviewed previously on this show. One of them was Dr. Tom Shea. He's an OBGYN here in Guam. So you know him?
Yes, I do. He trained here at the University of Hawaii.
Yes, he did. He did.
1 or 2 years ahead of me. But yeah, he's been a huge help and a partner and an advocate for HPV vaccine and cervical cancer screening, and it's just really important. So yeah, so those areas have really been tremendously strengthened. And then, like I mentioned earlier, there's a big focus in these next 5 years on increasing colon cancer screening, and this is also across the whole United States. But certainly Guam and CNMI, because they do have some capacity for screening, that is a really big emphasis. And working just with a lot of partners, community health centers, doctors in large group practices, and others to really make sure that everyone understands the importance of screening, and also making sure the insurance companies pay for it, because that's really so important. Yeah.
Right. And the other person also that we interviewed, actually just a couple episodes before this one, was Phyllis Camacho, and she is the producer and director of a documentary short, and I'm not sure if you've heard about it, but basically it focused on oral cancer in the CNMI and how it's so prevalent there because of betel nut chewing. And her documentary actually explores, the taboo behind it, the stigma behind it, and she mentioned almost everyone you come across either has oral cancer or knows someone who has oral cancer, and 90% of the island choose betel nut. So I see how this is going to be a challenge for you guys to try and combat this, especially since in the islands they kind of treat it as a cultural thing.
Right. And so there's been a lot of again kind of multidisciplinary work as well, and so. Several years ago, there was very focused effort in CNMI to train dentists and nurses and others to lick in the mouth to be able to screen for oral cancer. So in other words, don't just wait only for the problem in the dentist to do it, because you can screen for early signs. And what they found was that in some of the teenagers, there are those early signs. So they're not cancer yet, but if they continue to chew and it goes unchecked, then in 10 years it would be cancer. So, but they're starting to see some of that. It's called submucosal fibrosis in some of the teenagers in CNMI, and certainly also in Palau. And so so there's been a lot of effort and awareness to make people aware, first of all, that betel nut is bad. And yes, there's somewhat of a cultural argument, but then there are others that are trying to again work with the population to figure out ways. Well, betel nut didn't necessarily start here, right? It was imported, and so let's think about that a little bit, and try to reframe it.
Right. That's true. Well, so now going forward with your research, I know you mentioned that, like for example, cervical cancer, you won't really see the results of the prevention campaigns for another 10 or 20 years or so. But in terms of oral cancer, have you seen, whether it's Guam or CNMI, any reduction in cancer rates that deals with oral cancer?
Yeah, not yet,
Okay.
not yet. And part of the reason for this is one, it takes a while, for cancer to develop, and so the data that we do have in the cancer registries is from 2007 all the way to 2015. So what that means is that those patients would have to be diagnosed within that time period. Now, CNMI, Guam, I mean, they do have some data going back further, but it's not, maybe it's not 100% complete. It's not collected in the same way. So when we report out the incidence of cancer, or the amount of new cancers per year that develops, depending on which site and by age and sex and other things, it's based really on that 2007 going forward time period. So it's still a little too early to tell with the oral cancer in particular. But with cervical, because both jurisdictions have a breast and cervical cancer early detection program that is required to collect the abnormal pap smear results. So before it even becomes cancer, there's a whole variety of abnormalities that can happen. And so, we should, within the next few years, be able to see a decrease in the severe abnormalities. So, but with the rest of the cancers, we're not seeing a decrease yet.
Okay. Yeah. Well, we have just a few more minutes left on the show. I guess my last question to you would be, going forward for the research, for the project, what are some of the bigger goals that you have? I mean, obviously cancer prevention, but just as a whole within this region, what are you hoping to achieve?
Sure, thanks. So I think the big picture goals are, of course, try to get as much prevention as possible. And also on the screening side is really trying to increase the screening rates for the screenable cancers. So, cervical cancer with pap smear screening, it's not bad, but it's not great. Great meaning the standard is 80% or more of the population. And neither CNMI or Guam are at that yet. They're maybe in the low 60s. And so that's a big focus area, is just to try to increase the amount of screening, because then that's going to lead to earlier detection and treatments available on island and good outcomes and all of that. And then in terms of treatment, wise, it's hard because these CDC grants do not, you're not allowed to use the federal funds of these particular grants for treatment per se. It's really much more for education and capacity building. These particular, because they're pure public health grants, and public health grants, you cannot provide direct patient care. There are other grants that can, but these cancer program ones cannot. But certainly on the treatment side, we do there is going to be a priority on telehealth and trying to improve the availability of consultative services by Zoom, by using Zoom or Skype. But Zoom as a technology platform actually works well for everybody. But basically, we're really working hard to build that network so that at least for the initial part of it, they could actually consult with a cancer clinician, or maybe even a subspecialty cancer clinician, over the video like we are doing now, and do as much. The idea is to do as much of the diagnosis and screening and everything on island first, so that the resources that are needed to get someone off island are really used for or appropriately for the best thing, like for the actual treatment. Because right now, sometimes funds have to be spent to send people off island just for diagnosis, and then they've got to go back for treatment, which may extend a year. So we're really trying to work on the telehealth capacity between Hawaii and Guam and CNMI in particular, and throughout the U.S. The U.S. API. And then the other last big priority area is with palliative care and survivorship. So it is important to make sure that each island has appropriate services, so that once a patient is diagnosed with cancer, they have support available. And there's been a lot of good community agencies on Guam to kind of help patients through the different stages of their cancer journey. But palliative care is really more kind of towards the end of the journey. And, this is relevant if someone has cancer diagnosed at a late stage, there may not be too much that can be done treatment-wise, or may not be kind of at a curable stage. But it's still important to make sure that the patient and the family is well supported and understands, and that the patient's last days, months, years are comfortable. And so that those are the big emphases.
I see. All right. Well, Dr. Lum, thank you again so much for joining us on My Story. I myself have just learned a lot in talking with you about all of this, even though I've interviewed so many people about cancer and cancer in the region. We really appreciate your time, and we wish you a very Merry Christmas and Happy New Year out there in Hawaii. Thank you again for joining us.
Thank you.
All right. Well, we'll be right back to close out the show. Don't go anywhere. Welcome back, and thank you so much again for joining us in this episode of My Story. Thank you to Dr. Lee Buenconsejo Lum and to all those at the forefront of the fight against cancer. We hope, like us, you learned something new and you'll use that knowledge to spread awareness. Of course, this is all in an effort to prevent and eradicate cancer. From all of us here at My Story, Merry Christmas, Happy New Year, and have a good night.